Hi friends, in this video of respiratory system examination, today I will talk about percussion. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention and treatment of medical illnesses. There is no endorsement for any brand company. It is a chest percussion. It is a clinical method of tapping on the chest wall to assess the underlying structure. It helps us to differentiate between air, fluid or solid masses within the lungs or thoracic cavity. It helps in assessing or detecting the abnormalities in the lungs, pleura and thoracic cavity. It helps to differentiate air fluid, fluid filled or solid masses. The clinical relevance is it is useful in diagnosing the condition like pneumonia, pleural effusion, pneumothorax and lung consolidation. In while percussion, the fingers involved in the process have specific names. The percussing finger is also called the plexor finger. This is the finger which is used to strike during the percussion. Typically the middle finger of the dominant hand. It is called plexor finger, and percussed finger, this is the finger that is placed on the patient's body or the chest or the abdomen, and it is struck by the percussing finger, and this finger is usually of non-dominant hand, and this is the middle finger on the non-dominant hand, and it is referred as a pleximeter finger. In this picture we can see the percussing finger is plexor finger, and the finger which is being percussed is called pleximeter. How do we percuss? We have to place the middle finger of the left hand firmly on the chest area with slight hyperextension. Then we strike the finger with the tip of middle finger of the right hand, or vice versa for left-handed person, and movement should come from the wrist, not from the elbow. Percussing finger should be bent at right angles while percussing. So the common mistakes which we do is failing to apply left-handed finger flatly or firmly and striking from the elbow instead of wrist. How do we interpret the sounds produced while percussion? We call it as a resonant sound when we percuss healthy lungs. Dull sounds are heard or felt in when there is solid underlying lung consolidation or collapse. Tympanic sounds are produced by the gas-filled cavity, especially in the abdominal cavity or the stomach. The percussion areas in the chest which we usually percuss are anterior chest wall, involving the areas above the clavicle, also axillary regions, posterior chest wall, the areas above the scapulae, and we have to compare the left and right side systematically. In the chest, the most resonant areas are below the clavicle and the scapula, and least resonant areas are over the scapula in the posterior side, but it can vary between individual and the chest areas. Abnormal findings which we encounter are reduced resonance or dullness is seen in pleural effusion, consolidation or collapse, thickened pleura. Increased resonance is seen in pneumothorax, air in the pleural cavity. Pleural effusion shows stony dullness, decreased chest wall movement on affected side. It can be unilateral or bilateral. Similarly, pneumothorax, though it shows hyperresonance, but it may mimic dullness on one side. So to confirm, we have to do further examination and chest X-ray. Percussion of the chest is usually done in sitting position. Supine position is needed for demonstrating the shifting dullness. While percussing the anterior chest, patients sits up straight with hands by his side and percussion of the axilla. Patient raises the arm over the head and places over the back of the head. For posterior chest, patient sits up with hands crossed and placed over the opposite shoulder. Coming to the rules of percussion, first is the direction of the percussion. Always percuss from the resonant to non-resonant areas. The pleximeter is usually the middle phalanx of the middle finger of the left or non-dominant hand and is firmly placed on the surface while the rest of the fingers are slightly lifted off. Plexor or the plessor, the percussing finger, is the middle finger of the right or dominant hand. The movement of the plexor hand should be sudden and it should originate from the wrist. The pleximeter must be kept parallel to the border to be percussed. Percuss around 2 to 3 times over each area. Percussion has to be heard as well as felt. Always percuss the identical areas of the chest for comparison. The distance between the pleximeter finger and the ear should preferably be maintained. This is the picture showing how do we percuss the anterior chest, axilla and the posterior chest. Various types of percussions. Heavy percussion, it is the percussion over the posterior part of the chest. Light percussion, the anterior part of the chest and abdomen. Direct percussion, directly over the bony structures like clavicle. Indirect percussion, by percussing over the pleximeter finger with plexor or plessor. Auscultatory percussion, it was first described by Linnick to delineate the zone of organ by placing the stethoscope directly above the structure lobe outlined, followed by the percussion from the periphery towards the organ of interest. Direct percussion is the percussion. Here we percuss the middle third of the clavicle with plexor finger. We stretch the skin over the clavicle using the left hand. Normally, middle third of the clavicle is resonant, whereas the medial and lateral thirds are dull because of muscle attached. We hear or feel impaired node in apical fibrosis. Dull node is seen in mass-like lesion like Pankos tumor, and widening of the zone of resonance is seen in or heard in pneumothorax or emphysema. Flicking percussion is flicking using thumb and finger. It is done for percussion of the abdomen, cardiac border, and to check for the metallic note of pneumothorax. Guarino's method of auscultatory percussion. It is examined with patient sitting up and examiner facing the back of the patient. Place the stethoscope around the 3 cm below the last strip in the scapular line. Now percuss with free hand by finger flicking or with the pulp of the finger along 3 or more parallel lines from the apex of each hemithorax perpendicular downward and towards the base to note the dullness. Normal lung resonance or vesicular resonance. Front of the chest is more resonant as compared to back of the chest. Lesion more than 5 cm away from the chest wall or less than 2 to 3 cm, they usually do not alter the percussion note. Various abnormal type of percussion notes are they can be classified as quantitative or qualitative. Quantitative abnormal percussion notes are tympanic, subtympanic, hyperresonant, impaired note, dull or woody note, stony dull note, and qualitative are crackpot, amphoric, and bell tympanic. The quantitative types are tympanic note. It is a drum-like note, normally seen over the stomach, intestine, Traube space in chest, superficial cavity, subcutaneous emphysema. That is metallic tympanic note. Subtympanic is heard in, it is a boxy quality or we call it a Skodak note, just seen above the pleural effusion. Hyperresonant note, intermediate between normal and tympanic note. Bilaterally it is seen in emphysema. Unilaterally it can be seen in pneumothorax or compensatory emphysema or large bullae. Impaired note is seen in or heard in fibrosis or collapse. Dull note is felt or heard in consolidation or thick pleura. Flat dull can be altered by percussing over the thigh, seen in pleural effusion. Stony dull is pain over the pleximeter finger with resistance felt by the plexor. The quantitative type of resonance or cracked part resonance. It is seen in chest of infants and children during the act of crying. Pathological lung cavities which communicate with the bronchus due to sudden expulsion of the air from the cavity to the bronchus, they may produce cracked part resonance. It is artificially imitated by beating clasped hands over the knee. Amphoric resonance is low pitched, hollow note, normally seen in trachea and the cheek distended with air. It is pathologically seen in pneumothorax and large cavity. Bell tympani, it is high pitched, metallic or tympanic note, and it is massive, seen in massive pneumothorax. Here we place the coin on unaffected side of the chest and percuss with another coin while simultaneously auscultating the back. The hydropneumothorax produces dullness as a straight line, and the pleural effusion produces S-shaped curve of Ellis. If we percuss 5-7-9 rule is the upper border of lever dullness. Upper border of the lever dullness is the fifth intercostal space in the mid clavicular line, seventh intercostal space in the mid axillary line, and ninth intercostal space in the scapular line. Let's we do the percussion of the lung area wise. Apical percussion or chronic isthmus. Chronic isthmus is the band of resonance in the supraclavicular area bounded anteriorly by the posterior border of the clavicle, medially by the neck muscle, posteriorly by the anterior border of trapezius, and it extends laterally till the acromioclavicular joint. Here, examiner stands behind the patient, places the pleximeter finger over the neck and percuss from the lateral to medial. On percussion, there is a dull zone medially and laterally, and one middle part is resonant. Dullness in this area suggests the apical tuberculosis, Pank's tumor, or apical fibrosis. Zone of resonance may be widened in emphysema or apical pneumothorax. Coming to the tidal percussion, here tidal percussion is done to assess the diaphragmatic excursion, and we differentiate it. It helps us to differentiate the dullness above the diaphragm or below the diaphragm. Here we percuss the right chest from top down to find the lever dullness. Normally in the fifth intercostal space, we ask the patient to inhale deeply and hold the breath and repercuss the same area. Normally, when we repercuss the same area where we got the dullness, dullness moves down 1 to 2 intercostal spaces down. This is called tidal percussion. If in this area we again get dullness after asking the patient to deeply inhale, then it means that the dullness is because of above the diaphragm effusion or any other mass. So abnormal responses are seen in negative tidal percussion, right-sided pulmonic effusion, diaphragmatic paralysis, and emphysema. Percussion of the Traube space. Traube space is basically a place on the left inferior lateral chest which normally contains the gastric air bubble, and spleen is posterior to this gastric portion. Its border are superiorly, it is left inferior border of the sixth rib, and from inferiorly left costal margin, medially mid clavicular line, and laterally the mid axillary line. So it is a semilunar space in the left anterior chest, okay, bounded above by the fifth rib, below by the left costal margin, laterally by the mid axillary line. Normally in the Traube space, we get the tympanic note on percussion. Obliteration of the Traube space is seen in left-sided pleural effusion, pericardial effusion, massive splenomegaly, enlarged left lobe of the liver, full stomach, or fundic mass. Upward shift of the Traube space is seen in left diaphragmatic paralysis and left lower lobe collapse or fibrosis. So in this picture we can see the Traube space. How do we percuss it? Shifting dullness. It helps in assessing the hydropneumothorax and the pleural effusion. Purpose is to confirm the hydropneumothorax or pleural effusion. We percuss the anterior chest in sitting position, top down, to find upper border of dullness and mark the level of straight line dullness perpendicular to the body axis. Have patient lie down on opposite side 5 minutes or 30 minutes for 5 minutes for hydropneumothorax and 30 minutes for pleural effusion. Then we again re-percuss the affected side. So expected results are dullness shifts and becomes parallel to the body axis. Exceptions are there when there is it is absent in dullness is absent in emphyema or loculateral pleural effusion, and it may be negative in small effusions. So shifting dullness confirms the fluid movement in the pleural space, helps in differentiating the hydropneumothorax from the other condition, and but it is a time dependent, takes 5 to 30 minutes, and position dependent. Changing dullness is subject to the orientation of the patient. Special findings on the percussion. Shifting dullness is seen in hydropneumothorax. S-shaped Ellis curve of Ellis or Damasio curve is seen in pleural effusion, moderate pleural effusion. Obliteration of the Traube space is in left-sided pleural effusion. Grocos triangle, paravertebral triangle of dullness. Boundaries of the Grocos triangles are medially the mid-spinal line from the level of effusion to the level of 10th dorsal vertebra, below a horizontal line extending outward from the 10th dorsal vertebra along the lower limit of the lung resonance, literally a curved line connecting these two lines. It is seen over the back of the chest on the opposite side of the effusion in moderate to massive pleural effusion. Garland's triangle, small area of resonance next to the spine found in patients with large unilateral pleural effusion. Lower relaxed part of the lung in moderate or large pleural effusion is tympanic or subtympanic. Williams tracheal resonance. Here the area of tympani over the first or second intercostal space close to the sternum. It is seen in patch of consolidation of fibrosis interposed between the trachea and a major bronchus and the chest wall. It is referred to as a pulled trachea syndrome in fibrotic apical tuberculosis. Wintrich sign. It is a percussion note over the area during inspiration appears clearer and high-pitched with the mouth open, then it is closed. Seen in lung cavity communicating with the bronchus, pneumothorax and mediastinal tumor. Gerhardt sign. Here the percussion note is over the area, appears low-pitched with the patient recumbent than with him standing or sitting. Seen in lung cavity containing both fluid and the air. Friedrich sign is the percussion note over the area between the higher in pitch during forced inspiration than during the expiration, seen in lung cavity. This is the diagram of the posterior back which shows effusion, Roffesch-Grocot's triangle, Garland's triangle. First is the effusion, second one is the Grocot's triangle, and third is the Garland's triangle. Features of some common respiratory diseases with regards to mediastinal shift, percussion note, breath sounds, vocal resonance, and added sounds. For example, asthma, there is no mediastinal shift, percussion note is resonant, breath sounds are vesicular, prolonged expiration is thin, vocal resonance is normal, we get wheezes. Emphysema, no mediastinal shift, percussion note is hyperresonant, breath sounds are diminished, vesicular, prolonged expiration, vocal resonance and added sounds, vocal resonance is normal, and we get wheezing in emphysema also. In bronchitis, there is no mediastinal shift, percussion note is resonant, breath sounds are vesicular, vocal resonance is normal, and we get crackles. Bronchiectasis, no mediastinal shift, percussion note is impaired, breath sounds are vesicular, vocal resonance is normal, and we get coarse crackles. In fibrosis, Mediastinal shift is towards the same side. Percussion note is impaired. Breath sounds are vesicular, bronchial only if connected with the patent bronchus. Vocal resonance is diminished in fibrosis, and we can get crackles. In collapse, mediastinal shift is toward the same side. Percussion note is dull. Breath sounds are absent and rarely bronchial if connected with the patent bronchus. Vocal resonance is also diminished and we don't get any added sounds. Thick walled cavity, no mediastinal shift is there. Percussion note can be impaired. Breath sounds are usually cavernous and vocal resonance is increased. Added sounds are crackles. Thin wall cavity, the no mediastinal shift is seen. Percussion note is impaired. Breath sounds are amphoric. Vocal resonance is increased. We may get crackles. Pleural diffusion, the mediastinal shift is towards opposite side. We get stony dullness. Percussion note. Breath sounds may be absent and diminished vocal resonance. No added sounds are heard. In pneumothorax, mediastinal shift is towards the opposite side. We get hyperresonant percussion note. Breath sounds are diminished. Vocal resonance may be diminished and added sounds are none. Consolidation, we don't get any mediastinal shift. Percussion note is woody dull. Breath sounds are tubular and vocal resonance is increased. We may get crackles. So various types of percussion notes are normally it is heard in the normal lungs, that is resonance, impaired in fibrosis, dull in collapse, pleural thickening, consolidation, stony dull in pleural diffusion and empyema, hyperresonant in pneumothorax, tympanic in Traube space, Traube's area, crackpot resonance over large cavity communicating with the bronchus, shifting dullness in hydropneumothorax, straight line dullness in hydropneumothorax, obliteration of the cardiac dullness, emphysema, pushed down liver dullness, that is emphysema. Benjamin Franklin has said an ounce of prevention is worth a pound of cure. With this, I conclude my today's topic. Thank you. Keep learning.